Bismillah ar-Rahman ar-Rahim. I would like to welcome you all and take this opportunity to thank Dr. As-Sayyid Abdel Fattah and the organizing committee for giving me the opportunity to share with you this talk. And I'm going to talk about MODY and LADA, when to suspect and how to treat. This is my disclosure. And this is the content of my talk, the objective. We'll discuss the different types of diabetes and how to diagnose and how to manage. And I will end my talk by a case, and then we will conclude. I will start with this slide, and I hope that all of you agree with me that not all diabetes is the same. I'll take you quickly to the history of diabetes. And as you all know, that diabetes was first discovered by Hindu healers, 1500 before century. They wrote that flies and ants were attracted to urine of people with mysterious disease that cause intense thirst and worsening and wasting away of body. Similarly, the Egyptian also described a disease which shows as frequent urination and leads to emaciation, and they wrote this in papyrus paper and some of its treatments. Greeks also, they described a similar picture of melting down of flesh, and they are the first who put the term diabetes siphon to the disease. Indian physician also realized that there are different types of diabetes, one that occurs during young age and the other in obese adults, as Ibn Sina did as well. And he also differentiated Ibn Sina diabetes mellitus from diabetes insipidus. English doctor Thomas Willis, he added the term mellitus, which is sweet, to the term diabetes to differentiate it from diabetes insipidus. Let me take you now quickly to the different diabetes classification from the past to the present. WHO reports on classification on a regular basis, and we are going to discuss this later on. I'll just start that in the past, we used to classify diabetes based on age. So we used to call type 1 diabetes as juvenile onset diabetes and type 2 as adult onset diabetes. But what we learned that type 2 diabetes with obesity and insulin resistance happens in kids. And also we learned that type 1 diabetes, autoimmune disease, can occur in adults. And we have learned that there are other forms of diabetes, not type 1 or type 2 like MODY. And this is the slide here show you the peak incidence of different types of diabetes. And in the middle, you see that there are an overlapping gray area where you can have different types of diabetes and some diabetes where can be also unclassified. Also, once upon a time, we used to classify diabetes based on treatment. So we used to call type 1 diabetes as insulin dependent and type 2 as non-insulin dependent diabetes. And this was replaced by type 1 diabetes and type 2 diabetes. However, up to date, some people, they still label diabetes as insulin dependent and non-insulin dependent. We learned that people with type 2 diabetes, they may require insulin, but we cannot call them insulin dependent totally like type 1. And we learned that other form of diabetes, which may or may not need insulin, and we are looking into possible role of oral agents in other types and type 1 diabetes. We use also to classify diabetes based on the etiology to insulin deficient, like autoimmune disease, the type 1 diabetes and LADA, and the insulin deficient plus insulin resistance, like type 2 diabetes and MODY. We also classify diabetes to an autoimmune diabetes, like type 1 and LADA, and non-autoimmune diabetes, like type 2 diabetes, MODY, and other types of diabetes. This is a classical the diabetic classification that we currently use, type 1, which is with the prevalence of 10% with insulin deficiency, type 2 diabetes, which is the most common type of diabetes, characterized by insulin resistance and some relative insulin deficiency, and gestational diabetes, in addition to other types of diabetes. Among them includes the MODY and LADA, gestational diabetes, and other types of diabetes. So we learned that the current diagnosis is imprecise. Sometimes flatbush diabetes that present with diabetic ketoacidosis turn out to be type 2 diabetes, and this is what we call ketosis-prone diabetes. We have LADA, typical of type 1, but it is not type 1. Antibody positive, who looks like type 2. Type 1 diabetes with insulin resistance, like type 2 diabetes, and complicated by extensive overlap between the different types of diabetes. In 2018, it was published a new classification of diabetes based on different categories that was published in Lancet Diabetes and Endocrinology, and they classified into 5 categories. The first cluster is similar to type 1, and the remaining 4 clusters are subtypes of type 2, among them what looks like MODY as well. However, I'm not sure that people are using this type of classification, and it looks to me a bit difficult to use in practice. This is the WHO updated classification. They have added to the type 1 and type 2 other specific types of diabetes, and among those different other types of diabetes, they have included what looks like MODY and LADA to be included, which was not there in the past classification. So let me ask this question. Is it really important to diagnose clearly the type of diabetes, or it is not important? Doesn't matter which label we are apply. We can just say that this patient is insulin requiring. If he doesn't take insulin, he will go into ketoacidosis without insulin. And the other types is independent of age, labeled to the best guess and treated with the best treatment. Is that applicable or not? In fact, this is not true. We need to have a diagnosis and clear diagnosis because it may have many functions that include planning of care, predict who will develop this kind of disease. Prevention also is important, especially in people with like type 2 diabetes, proliferative scientific knowledge about diabetes. So we need to classify accurately the type of diabetes. So now let me start with MODY. MODY, or what called maturity onset diabetes of young. This is type 2 diabetes in young and autosomal dominant inheritance. It accounts of 2% of diabetes worldwide. We have to differentiate MODY from childhood type 2 diabetes, which is characterized by significant insulin resistance, which is distinct and different from both type 1 diabetes and MODY. First, terminology of MODY was described in 1965 and first mutation in 1992, with subsequent development of and discovery of different mutation. And up to now, we have almost 14 subtypes of MODY. MODY is a mutation in one of the different genes. The same gene are expressed in other tissues like the liver and kidney, which may present also in complications in those people with MODY, liver and kidney complications. And the onset of diabetes in MODY is earlier than what happens in people with type 2 diabetes or childhood. It presents in childhood or adolescence. And the primary defect here is in the defect in the insulin secretion. So let me take you quickly here to the glucose regulation and release, insulin release. As you know, glucokinase plays a major role in the regulations and glucose sensing, resulting in glycolysis. And similarly, the hepatocyte nuclear factors are important also in the insulin secretion. So what happens if we have gene mutation in glucokinase or in the hepatocyte nuclear factors? We will get impairment in glucose stimulation and insulin secretion, and this is exactly what is MODY. MODY is an autosomal dominant inheritance, and if the mother have MODY, the likelihood of the child to have MODY is 50%, and it accounts, as we mentioned, between 1 to 5% of diabetes in youth. And I'll just ask you, how many of those young people with MODY have been misdiagnosed as type 1 diabetes and treated with insulin? MODY, as we mentioned, occurs in younger age group, age less than 25. They have mild fasting, non-ketotic hyperglycemia. They don't have ketoacidosis. They are non-obese. They have strong family history, and they have absence of signs of insulin resistance or mild insulin resistance. They have absence of marker like antibody markers, GAD antibody and beta cell antibody, and they may have cystic kidney disease in patients or close relatives, liver adenoma or hepatocellular carcinoma in MODY 3. This is showing the differentiation between MODY and type 2 diabetes. MODY occurs at a younger age than type 2 diabetes. They are non-obese. They don't have the significant signs of metabolic syndrome. The majority of patients with MODY, they are genetically proven monogenic diabetes, are initially incorrectly diagnosed, as I mentioned, like with the diagnosis of type 1 and type 2 diabetes, and this will result in incorrect management. Correct diagnosis is important, as we mentioned earlier, to predict the clinical course, explain other associated clinical features, and also screen for those other complications, guide the most appropriate treatment, and allow appropriate diagnosis of other family members and appropriate genetic counseling. These are the different MODY genes. As we mentioned, we have up to 14 MODY types, subtypes of MODY, and I'm going to concentrate on the upper first MODY 1, 2, 3, as they are the most common, and the remaining are not as common and they are rare. MODY 3 is the most common among all MODY types, and it is the most severe form of among the three types of MODY, and it accounts for about 65% of MODY cases, and the defect here is in the hepatocyte nuclear factor 1 alpha gene. As we mentioned, they are non-obese. They are the most important thing that they are very sensitive to sulfonylurea. So, and they may progress to insulin need, and they are prone to develop retinopathy, nephropathy, and cardiovascular disease like people with type 2 diabetes. The next common MODY is MODY 2, account for up to 25% of MODY cases, and the defect here is in the glucokinase gene. It is a milder form than MODY 1 and MODY 3. And MODY 1 accounts for up to 5% of MODY cases, and the defect here is in the hepatocyte nuclear factor 4 alpha. It's a progressive disease again, and similar to MODY 1. MODY 1 is similar to MODY 3. They fulfill the spectrum of type 2 diabetes. They may develop complication, and the complication is linked to the duration of the disease and the control. MODY 2 is the less severe form of the other types of MODY and may be managed only with diet and observation. So when do you suspect MODY? You suspect MODY and the diagnosis of type 1 is not correct. If you have a diagnosis of diabetes at age less than 6 months, family history of early onset of diabetes, evidence of endogenous insulin, and also the C-peptide and proinsulin is not absent. They have detectable C-peptide, and islet antibodies are absent. And the diagnosis of type 2 diabetes may be not correct, and the diagnosis of MODY should be suspected if the person with diabetes have absent obesity or overweight, and they are younger than 25 years old. They don't have significant or severe insulin-resistant signs like acanthosis or lancurocans. They may have mild only in some of the population with MODY, and they have normal C-peptide and absence of insulin resistance. So individual or family of history of diabetes paired with the development of kidney disease or kidney cyst, you should always also suspect MODY. MODY phenotype, that the clinical spectrum of MODY is extremely varied and they can overlap. And as a consequence, many patients with MODY, they remain undiagnosed or misdiagnosed with inappropriate treatment. How would you diagnose MODY? Based on clinical basis, as we mentioned, the early onset of diagnosis, the non-insulin dependent diabetes, the autosomal dominant, and the way to confirm the diagnosis is by genetic testing, whether it's blood or saliva. However, unfortunately, this test might not be available readily in all centers. And the non-genetic testing include looking at the C-peptide, which is usually detectable in people with MODY, and the level ranges between 0 to 1 as compared to people with type 1 diabetes, where they will have undetectable or very low C-peptide, and people with type 2 diabetes, they have detectable and maybe even high C-peptide. In addition, they don't have signs of insulin resistance, and the HDL to triglyceride ratio is also high, but it is not at the level of type 2 diabetes, while in type 1, they have normal with no signs of insulin resistance. So this is how you differentiate MODY from type 1 and type 2 diabetes. In one study, they looked at the C-reactive protein, the high sensitivity C-reactive protein, and they found that people with MODY 3, they have lower high sensitivity C-reactive protein. This could help in making the diagnosis, and I'm not sure whether it's applicable or not. The most important issue here is the management. That's why it's important to diagnose people with MODY carefully and manage them adequately. In this study, those people in the study were managed with glipliclamide here. And at this stage, they stopped the sulfonylurea glipliclamide and they started them on metformin. And what they found that the blood sugar will subsequently increase. And when they replace them back again on sulfonylurea glipliclamide, you can see the significant reduction of their blood glucose. So that indicates that sulfonylurea resulted in 4-fold greater lower of glucose than metformin, and sulfonylurea provide better glycemic control in people with MODY to achieve control even as compared to insulin. So that's why the current International Society of Pediatric and Adolescent Diabetes, they recommended that all people with MODY 3 should be switched from insulin to sulfonylurea. However, despite this recommendation, still up to 40% of people with MODY 3, still they are receiving and managed with insulin treatment. So insulin treatment was associated with higher A1C and higher risk of hypoglycemia. So all people with MODY 3 should be managed with sulfonylurea. In case the blood sugar is not controlled, other drugs could be added that may include insulin, as we are going to discuss. So the treatment here for MODY 3 and MODY 1, diet, sulfonylurea, insulin if they fail to be controlled with the other management. For MODY 2, they usually don't require treatment and they may be managed with diet alone. Other type of MODY treatment is unclear and may require multiple daily injection of insulin. About the DPP-4 inhibitors, actually, it has modest effect, and one study showed that linagliptin resulted in good control without the risk of hypoglycemia, so it should be an option to add to sulfonylurea if they are not controlled. GLP-1 receptor agonist, again, one study revealed that liraglutide helped people with MODY 3 if they are on insulin to control A1C and reduce or discontinue insulin. So it could be an option to add on to sulfonylurea, and as well as in MODY 1, but the rule as first-line therapy is not established yet. Remains sulfonylurea as the first-line therapy for people with MODY. What about SGL2 inhibitor? SGL2 inhibitor induces higher glycosuria in individuals with MODY 3. Glycosuria in MODY 3 is due to reduced expression of SGL2. And one reported study, they showed that people given SGL2 inhibitor demonstrated severe dehydration and diabetic ketoacidosis. So up to date, the risk of the treatment with SGL2 inhibitor in MODY 3 outweighs the benefit, and we don't have clear recommendation for using this drug in people with MODY. And this is the timeline for the management of MODY. Sulfonylurea remain the most standard treatment. GLP-1, DPP-4 could be an alternate. SGL2 still is probably not safe to be used until we have more clearer recommendation. So the MODY birds, MODY is similar to type 2 diabetes as they have mild symptom or no symptoms of diabetes when they present. They have normal C-peptide and they can be managed with diet sulfonylurea plus minus insulin or other oral agents. MODY is against the diagnosis of type 2 diabetes as they present at earlier age. They have absence of obesity and insulin resistance signs. MODY is similar to type 1 diabetes in view of the early onset of age. They are non-obese and they don't have insulin resistance. And MODY against type 1 diabetes as they have mild or no symptoms. They don't have diabetic ketoacidosis and they have normal C-peptide and negative antibody. If you suspect MODY and the patient have GAD negative detectable C-peptide, then you should treat them with diet and sulfonylurea, not to initiate insulin at the beginning. And you should screen for chronic complication in MODY 1 and 3, and screen also for cystic kidney disease in the liver and the kidney, as well in MODY 3. So let us now move to LADA. LADA, also called double diabetes or diabetes 1.5. It is the occurrence of insulin deficiency and mild insulin resistance in some patients. The prevalence is up to 12% of diabetes cases. These are the different names given to LADA. LADA is a latent autoimmune diabetes in adults. It's also called skinny type 2, 1.5 diabetes, latent type 1, slowly progressive type 1, double diabetes, and these are all the terminology. LADA is an immunologically similar to type 1 diabetes, but immune destruction progressive at a much slower rate when compared to people with type 1 diabetes. So when do you suspect LADA? When you have a patient diagnosed with type 1 diabetes, the diagnosis is wrong if the occurrence of the diabetes occurred at onset of age more than 25. They have family history and they have signs of insulin resistance. Their C-peptide is positive, maybe low or normal, and they may have also initially controlled with nutrition and oral agents. They don't present with diabetic ketoacidosis initially requiring insulin. And also the diagnosis of type 2 diabetes may be incorrect, and you should suspect LADA if they are not obese, they have no insulin resistance signs, they have no ketones in the urine, the presence of other autoimmune disease like Hashimoto's and celiac disease, and also if they have positive for autoantibodies, GAD and islet cell antibody, and they have low C-peptide, then you should always suspect LADA, and the diagnosis of type 2 is wrong. So diagnosis of LADA should also be discriminated from the ketosis-borne diabetes, which is another type of diabetes. Ketosis-borne diabetes is atypical. It's not really type 1 or type 2. It is a little bit of both of them. They present at earlier age. Earlier reports use the term atypical diabetes, called it also flatbush diabetes, or most commonly we call it ketosis-borne type 2 diabetes. It's an uncommon form of diabetes characterized by severe initial reversible insulin deficiency. So the patient may present with diabetic ketoacidosis, and they are negative for GAD antibody. These people, most patients with ketosis-borne diabetes, although they will require insulin initially, however, insulin may be discontinued later, a few months later, and treated with oral agent. LADA is often confused and misdiagnosed as ketosis-borne diabetes, as ketosis-borne diabetes are usually similar to type 2 diabetes. They are obese, they have strong family history, have a low prevalence of autoimmune markers, and should always suspect ketosis-borne diabetes, not LADA. So it is necessary to differentiate between LADA and ketosis-borne. LADA is always requiring insulin, while ketosis-borne, although initially they require insulin, subsequently may be managed by oral agents. LADA, the early initiation of insulin therapy is mandatory, while ketosis-borne, although they are initially managed with insulin, subsequently they be managed with oral agents. So when do you suspect ketosis-borne diabetes, and the diagnosis of LADA is wrong? If you have an obese person, significant insulin resistance, rising level of C-peptide initially may be low and it may increase later, negative autoantibodies, and the diagnosis of type 1 is not the correct diagnosis here. If the individual is obese, strong family history, age more than 25, they have markers of insulin resistance, autoantibodies are negative, rising level of C-peptide, then you should suspect ketosis-borne diabetes, not type 1 diabetes. Who should be tested for LADA? You should consider testing with antibody. Those who are age above between the age of 25 to 50 with acute symptoms, maybe presentation with diabetic ketoacidosis, they are not obese, and when they have a detectable C-peptide. The potential value of identifying this group is the high risk of progression to insulin dependent. So if you diagnose them with a positive antibody, you should initiate insulin, although they respond earlier to oral agent, but you should preserve the beta cell by starting them on insulin and not to use sulfonylurea that may quickly deplete the beta cell and results in more severe form of insulin requirement. The LADA diagnosis based on the GAD antibodies and the islet cell antibodies, and a high C-peptide with an occurrence in which occur in type 2 diabetes rules out LADA, and anti-GAD antibody need not to be tested in this group. However, if you have a detectable C-peptide but at a low level or normal range, then GAD antibody should be tested if you suspect LADA. So If you have GAD antibody positive, C-peptide low or normal, then LADA should be suspected. If you have GAD antibody negative, C-peptide level in the normal or high range, then type 2 diabetes should be suspected. If you have HDL to triglyceride ratio more than 4, then insulin resistance should be suspected. If significant insulin resistance, then this is probably type 2 diabetes, not LADA. So how would you treat LADA? LADA often does not require insulin at the time of diagnosis. They can be managed with diet, exercise, or sulfonylurea. However, this recommendation is not required. We should always avoid sulfonylurea, as we mentioned, to save the beta cell. Even metformin should be avoided as the risk for lactic acidosis, and TZDs also may play some role as it has an anti-inflammatory characteristic that may help in some people with LADA. However, also DPP-4 inhibitor and GLP-1 receptor role is not determined in people with LADA, and insulin remain the standard treatment of people with LADA to preserve the beta cell function. Many require multiple daily doses of insulin, and if GAD positive, you should always start insulin, even if they respond to diet and sulfonylurea. You should stop sulfonylurea and start insulin immediately. So LADA burn, LADA is similar to type 2 diabetes as the age of onset is above 25. They have some or mild insulin resistance or no insulin resistance. They can be managed with oral agent. LADA is against type 2 diabetes as people with LADA, they may present with severe symptoms and diabetic ketoacidosis. They have rapid progression to insulin therapy. They have low C-peptide and positive antibody. LADA is similar to type 1 as they are, as we mentioned, non-obese. They have other autoimmune disease, positive antibody, and low C-peptide. LADA is against type 1 in view of the age of presentation. Initially, they can be managed with diet and oral agent, which is not the situation in people with type 1. And if you suspect LADA and patient has positive GAD antibody, then you should immediately start insulin and screen for other autoimmune disease like thyroid disease and celiac disease. So as you have seen, there is a significant overlap between the different types of diabetes that include overlap in the age and body weight and insulin resistance. Current diabetes classification will depend on really your good history and looking at the clue to make the appropriate investigation, diagnosis, and the appropriate treatment. So let me end my talk by this case. This is a 42-year-old woman presented with new onset of diabetes. She has 6 weeks history of fatigue, thirst, blurred vision, polyuria. She has history of hypothyroidism, hyperlipidemia, depression. She is on replacement therapy and on statin treatment and antidepressants. Family history, her son has type 1 diabetes, and her physical examination revealed the BMI of 22.6, and her A1C is 10% with normal renal and liver function. Her HDL is low, triglyceride is high with the ratio of 2-folds only. So what do you think is the diagnosis of this lady diabetes? Is it type 1, type 2, ketosis prone, LADA, or MODY? So if you would like to ask for more tests to confirm your diagnosis, this patient had GAD antibody, which is positive at 94.9, so it is very elevated. Her C-peptide, although it is detectable, 0.9, but it is low. It is not in the level of type 1 diabetes, which is usually undetectable or below 0.3. This patient has detectable but low C-peptide. So the diagnosis of this patient, the most likely diagnosis, this patient has LADA, latent onset diabetes of adults. And LADA is because her age is above 25, she is not obese, and she has some evidence of insulin resistance, although it is not severe. Her HDL to triglyceride ratio is less than 4. It was only 2. She has low C-peptide, positive antibody. She has autoimmune disorder, hypothyroidism, and within short time, if this patient is not started on insulin, she will develop severe hyperglycemia and maybe diabetic ketoacidosis. So what would be the best option of treatment for this patient? definitely insulin. This patient should be started on insulin and continued on insulin. So in conclusion, ladies and gentlemen, MODY, maturity onset diabetes of youth, is type 2 diabetes mellitus in young and autosomal dominant inheritance, present like type 2, but has some characteristic like type 1, presents like type 2 with mild hyperglycemia, GAD negative, and normal C-peptide or low C-peptide, managed with diet, but has some characteristic like type 1, age of presentation less than 25, no insulin resistance, they are non-obese. So misdiagnosed commonly as type 1 diabetes. LADA, latent autoimmune diabetes in adult, may present like type 1 diabetes, but has some characteristic like type 2 diabetes, may present with diabetic ketoacidosis. They have GAD antibody positive, low C-peptide but detectable, has some characteristic like type 2, age of presentation is above 25, mild insulin resistant, and can be initially managed with sulfonylurea. If you diagnose LADA, they are always misdiagnosed as type 2 diabetes. If you diagnose MODY, the treatment will be with diet, sulfonylurea. LADA, you should treat with insulin only. So to conclude, MODY LADA is one area in which clinical observation has led and will continue to lead to scientific advances. With that, I would like to thank you very much.